Great, thank you so much. Good afternoon, everyone. So my name is Yuri. I'm a cardiologist from Brigham and Women's Hospital, which is a teaching hospital of Harvard Medical School in Boston. First of all, I'd like to thank President Chung and the committee for inviting me to give a presentation today. And I'm very excited to be here, and congratulations for Kimcheon Hospital for opening this neurovascular center. So today, I would like to discuss diagnosis and management of the heart failure. And as many of you are aware, that patients with a neurovascular disease also have cardiovascular disease. And one of the complications is a heart failure. And that's why I wanted to discuss this topic with you today. So I would like to start with a brief patient case for today's talk. So patient that we'd like to discuss is a 63-year-old man with past medical history of polymyalgia rheumatica on prednisone, and also has a history of minor ischemic stroke, but no residual deficit, who presented with a 3-month history of worsening dyspnea on exertion. He states that he noticed dyspnea on exertion and mild chest pressure for the past 3 months. And also, he noted orthopnea, which he initially attributed to cold. But his symptoms worsened over the last few months, so he decided to present for further evaluation. His past medical history, again, is notable for PMR, polymyalgia rheumatica. He has history of Lyme disease, which was treated with antibiotics. He also has history of hyperlipidemia, and remote history of ischemic stroke. And his allergies include shellfish and penicillin. He takes prednisone and atorvastatin daily for his medications. His family history is notable for brother who also has heart failure that was diagnosed at age 55. His parents are both alive and well in their 80s. In terms of social history, he is married with 2 children in their 30s, and they are in good health. He works as an architect. He used to smoke cigarettes but quit after having a stroke. And he drinks alcohol occasionally and denies having any illicit drug use. On physical exam, vital sign is notable for heart rate of 128, which is fast. And he had oxygen saturation of 94% on room air, which is low. Other notable exam findings included elevated jugular venous pressure at 13, diffuse bibasilar rails. He also was noted to be tachycardic and had S3 on cardiac auscultation. And his extremities were notable for 1+ feeding edema, which is indicative of volume congestion. His blood test demonstrated that he has normal troponin, but elevated BNP, again suggestive of having volume overload, and mildly elevated creatinine at 1.2. He underwent CT chest with IV contrast, given his concern for dyspnea, which showed no pulmonary embolism, but small bilateral pleural effusions. His electrocardiogram is demonstrated here, and it shows sinus tachycardia at heart rate of 110 beats per minute. Also has occasional premature ventricular complexes, right bundle branch block, and left atrial abnormalities. Given his symptoms concerning for cardiac etiology, he underwent transthoracic echocardiogram, and here are a couple of images. Just for those who are not familiar with echocardiogram, so this is a picture of the heart, and this is the left ventricle, this is the right ventricles, and again here you can see the left ventricle, right ventricles, and these images demonstrate that patients have dilated heart, that's a big heart, with a severely reduced function, and ejection fraction was estimated to be about 12%, and normal is 50%. So this patient has severely dysfunctional heart, and that's likely causing this patient to have difficulty breathing. So given his clinical symptoms and this evaluation so far, our impression was that patient has clinical diagnosis of heart failure. So let's take a step back and think about what heart failure is. So heart failure is defined as a clinical syndrome with current or prior signs of cardiac dysfunction. And also it is corroborated by at least one of the following, which includes elevated natriuretic peptide levels and objective evidence of systemic congestion. So our patient has cardiac dysfunction, which is the abnormal heart function, and also elevated BNP level on blood test. In addition, he has evidence of systemic congestion, which is evidenced by difficulty breathing, pitting edema, and pulmonary edema and pleural effusion. Therefore, our patient has clinical diagnosis of heart failure. Heart failure is classified to have 4 stages: stage A, B, C, and D. Stage A patients are those at risk of developing heart failure. So these patients do not have heart failure yet, but they have risk factors for developing heart failure in the future, such as diabetes and hypertension. Stage B patients are called pre-heart failure patients. They have abnormal structural heart disease, but they do not have any active symptoms of heart failure. So for example, patients who has low ejection fraction but no heart failure symptoms will be stage B. Stage C patients are the most common type. So those are the patients who have current or previous symptoms of heart failure. And the last, stage D, are those with advanced heart failure. So these patients has advanced disease and they have recurrent hospitalization because of the heart failure, or they are not able to tolerate any cardiac medications because of the low blood pressure. So these are patients with advanced disease. Another way to look at heart failure is by ejection fraction, so degree of the heart pumping function. So patients with a reduced pumping function of the heart, which is the ejection fraction, so they are called half-RAF. There is another class of heart failure called heart failure with mildly reduced ejection fraction. And the third type is heart failure with preserved ejection fraction. And the last category is heart failure with improved ejection fraction. And we think of this classification of heart failure because treatment and medication that we use for these different type of group of patients are different. So our patient would be heart failure stage C because he's currently having heart failure symptoms, and also he has heart failure with reduced ejection fraction because his ejection fraction was 12%, which is less than 40%. So heart failure is caused by a disease of myocardium, which is called cardiomyopathy. And when we think of cardiomyopathy, we often think of these big 3 categories based on their morphological features: hypertrophic cardiomyopathy, restrictive cardiomyopathy, and dilated cardiomyopathy. So hypertrophic cardiomyopathy patients have thickened ventricular wall, as shown by these figures. The heart muscles are thick, and that's why they are called hypertrophic cardiomyopathy. Another group is restrictive cardiomyopathy, meaning that their cardiac muscle is very stiff and restrictive, and that's why they're called restrictive cardiomyopathy. The most common type of cardiomyopathy is called dilated cardiomyopathy, which is shown at the bottom. And this cardiomyopathy is characterized by dilated chambers in large heart, as shown in these figures. And when we think about dilated cardiomyopathy, we think about 2 big groups, which includes ischemic cardiomyopathy that is caused by obstructive coronary artery disease, meaning that there's a blockage in the arteries around the heart. And there's another group called non-ischemic cardiomyopathy. And non-ischemic cardiomyopathy can be caused by various reasons. It could be from genetic mutation. It could be from acquired condition because of other comorbidities such as hypertension, tachycardia, and cardiotoxic agents such as alcohol or chemotherapy can cause cardiomyopathy. Other systemic diseases such as sarcoidosis and thyroid disorders can also cause cardiomyopathy. And after thorough evaluation of coronary artery disease and many other etiologies, sometimes we are still left without any obvious cause for patient cardiomyopathy, and they are called idiopathic cardiomyopathy. So how do we evaluate patients when they first present with a cardiomyopathy? We often start by evaluating for coronary artery disease to make sure that patients do not have blockage in the arteries around the heart. And to do so, we often perform coronary angiogram. I know we've seen many angiograms of the brain blood vessels in previous talk, but we can also look at the arteries around the heart to make sure that there is no blockage. So we perform the coronary angiogram, or we can perform the CT scan of the arteries around the heart to make sure that there is no blockage around the arteries that's causing the cardiomyopathy. In addition, we can also evaluate for non-ischemic cause to figure out why these patients have cardiomyopathy. And this is some of the evaluation that we often perform in the United States. So we send off many blood tests to evaluate for infectious etiology, amyloidosis, autoimmune disorders, thyroid disorders, hemochromatosis, because these can all cause cardiomyopathy in our patients. Also, we can perform imaging studies such as MRI, PET-CT, PYP scan, and also genetic testing to evaluate for etiology of cardiomyopathy. So in our patient case, given that he presented with new cardiomyopathy, we performed coronary angiogram, and it demonstrated that patient has some blockage in the arteries around the heart, but degree of blockage did not explain his severe dysfunction of the heart. So in addition, we performed additional evaluation using blood tests, but many of them came back normal. And we also performed MRI of the heart to figure out if we can identify the cause of this cardiomyopathy, and it was inconclusive. Therefore, our diagnosis at the end was that this patient has non-ischemic idiopathic dilated cardiomyopathy leading to heart failure with reduced ejection fraction. So now we have a diagnosis. How do we manage these patients? What are the treatment options for these patients? And I'd like to review that with you for the remaining time of the talk. So here are some examples of the clinical trials that were shown to improve survival in patients with HFrEF. And I think in cardiology, actually, we are very fortunate to have a lot of data, and we can use this evidence to guide our treatment plans. And here you can see many of the familiar medications such as isosorbide, hydralazine, ACE inhibitors, beta blockers, and also device therapy that we often use for patients with heart failure such as ICD, CRT, and LVAD, ventricular assist device, and other new medications such as ARNI and SGLT2 inhibitors. So based on this clinical trial data, we have this clinical guideline that we often refer to take care of patients with heart failure. So this is the most recent guideline for management of heart failure that was recently published by American Heart Association. And you can see that for patients with reduced ejection fraction, that there are 4 groups of medication that we often use. We call them 4 pillars of medication for heart failure, which include ARNI or ACE medications, beta blockers, MRA, which stands for mineralocorticoid receptor antagonist, and SGLT2 inhibitors. So what are the evidence behind recommending these medications? So let's start with MRA, which is the old medication that many of us have been using for many years. And it's remarkable how this medication actually helps our patients in different clinical scenarios. So here are 3 big clinical trials that have demonstrated survival benefit of this medication in patients with heart failure. And trials have shown that heart failure with severe symptoms or heart failure with mild symptoms, or heart failure who just had a heart attack, in any clinical scenario, this medication actually improves their survival. Therefore, we want to make sure that we use MRA medication for patients with a heart failure. And the next group of medication is called Arni, and this is one of the newer medication, and it's also known as Entresto, is a brand name. So the benefit of Arni in patients with heart failure was demonstrated in clinical trial called Paradigm-HF. And in this trial, the investigators used Entresto, which is actually a combination pill. So it consists of two medications. One is the valsartan, which is the angiotensin receptor blocker, and the other is neprilysin inhibitor, also known as sacubitril. And how Entresto works is two mechanisms. So it actually works by decreasing the harmful signaling pathway through valsartan, and also it's promoting the beneficial pathway through sacubitril. So overall, you gain a greater benefit in improving patients with heart failure. And when you look at their data from this trial, you can see that Entresto group has significantly decreased the death from cardiovascular cause and also heart failure in patient population with heart failure, as shown by these significantly low p-values. Therefore, we also like to make sure that we prescribe Arni to patients with heart failure. And the next group of medication, which is one of the newest medication, is called SGLT2 inhibitor. So this was the new update to our clinical guideline that was published this year. And the evidence behind this medication comes from this recent clinical trial called DAPA-HF. So what is this SGLT2 inhibitor? And actually what is very interesting about this medication is that this medication was developed as a diabetes medication. It was not a heart failure medication. It was initially developed as a diabetes medication because SGLT2 is a glucose transporter that is located in the kidneys. So this transporter transports the glucose from the urine to the body. So if you inhibit this transporter, then the level of glucose in urine increases, but the level of glucose in body decreases. Therefore, the glucose level in the patient goes down, and that's how it treats the diabetes. But what was interesting is that when patients were taking this medication for their diabetes, the investigators found that actually patients who are taking SGLT2 inhibitor has a better cardiovascular outcome, which led to further study of this medication in patients with heart failure. So this DAPA-HF trial studied the effects of SGLT2 inhibitor in patients with heart failure and have demonstrated that patients who are taking this medication has significant decrease in mortality and also heart failure, again demonstrating the benefit of this medication for patients with heart failure. And what was very interesting is that when they performed subgroup analysis, they realized that patients, the benefit with this medication comes in different clinical scenarios. So regardless of their age, gender, race, this medication seems to be working well. And also what is very interesting is that even patients without diabetes, this medication still benefits the patients. So based on this data, we do not view SGLT2 inhibitor as a diabetes medication only, but we also view that medication as a heart failure medication. And we prescribe SGLT2 inhibitor in patients with heart failure, even without the diabetes. And one thing that I'd like to note is that actually SGLT2 inhibitor also improves the kidney disease, which is actually incredible, that how many benefits this medication can offer to patients. And this SGLT2 inhibitor actually initially decreased the GFR in patients, but overall, over the long term, you can see that patients who are taking SGLT2 inhibitor has improved kidney function compared to those without. So based on this evidence and clinical data, so this is a summary of how we often think about when we treat patients with heart failure. So if the patient presents with heart failure, we try to prescribe these 4 classes of medications, including ACE inhibitor or ARNI, beta blocker, MRA, and SGLT2 inhibitor. So these are the 4 pillars of medications that we try to prescribe to patients with heart failure. And based on clinical scenarios, we prioritize one class of medication over others. So for example, if patient with heart failure has recent myocardial infarction, the heart attack, or evidence of active ischemia, or tachyarrhythmia, such as atrial fibrillation or ventricular tachycardia, we try to prioritize prescribing beta blockers, given the benefit of beta blocker for ischemia and tachyarrhythmias. If the patient were to have heart failure and also chronic kidney disease, we try to prioritize SGLT2 inhibitor or ACE inhibitor or ARNI, because the previous data demonstrated that these medications also help patients with a kidney disease. So we talk about the medical therapy for patients with a heart failure, and once the medical therapy is optimized, then we also consider prescribing with a device therapy such as a defibrillator, cardiac resynchronization therapy to further optimize management of these patients. But I'd like to also bring up this stage called refractory advanced heart failure, because unfortunately that's what a lot of our patients with heart failure end up being at the end of their life. So what is quite discouraging about this disease, heart failure, is that many patients initially present with heart failure, they improve with the treatment and medication, but unfortunately over time their clinical condition deteriorates and worsens gradually, and at the end they develop end-stage heart failure leading to their death. So what is this end-stage heart failure and what can we do for their patient? So end-stage heart failure is characterized by severe symptoms of heart failure, and these patients often get short of breath, even with walking very short distance, and they're not able to even get changed or take a shower because they get short of breath. They tend to lose weight because of the heart failure. They have a hyponatremia. They also are unable to tolerate any cardiac medications because their heart is too weak, and they become hypotensive, meaning that their blood pressure becomes too low. And in this setting, in the United States, we often think about 3 options. We often offer them palliative care to kind of improve their quality of life, given this end-stage heart failure. We can also offer them inotropic support, which is a continuous IV medication to help them feel better. Or we can offer them advanced therapy, which is often either heart transplant or the ventricular assist device, which is the machine that can support the heart function. And for the last couple of minutes, I just wanted to briefly tell you about this mechanical circulatory support device, which is what we use for patients with end-stage heart failure. So in the acute setting, when it is temporary, these are the temporary mechanical circulatory support device that we use to support patients' sick heart. So these are called the balloon pump, Impella, tandem heart, and ECMO. So these are different types of device with a different support level that we can help the patients to overcome the temporary situation when they're very sick. But for chronically, if the patient has end-stage heart failure and they need to go home despite this end-stage heart failure, then we can offer them something called LVAD, which stands for left ventricular assist device, and the trade name is HeartMate 3. So this is a surgically implanted device that is actually connected to the apex of the heart and the aorta, as shown here, and the driveline, which is the electrical cord that comes out of the patient, and that's connected to the battery. So patients with end-stage heart failure can undergo this surgery and they can have a reasonable quality of life with this mechanical support network. And the recent clinical trials have demonstrated that great benefit of these LVAD machines compared to medical therapy. So here on the graph on the left, compared to the conventional medical therapy, this device, the LVAD device, greatly improves the survival in patients with end-stage heart failure. And this is the most recent data with the newest pump, which is called HeartMate 3, and it again demonstrates that HeartMate 3 improves the outcome compared to the older version of the HeartMate 2. So these data, based on this data in the United States, so we offer patients the medical therapy for heart failure, but if they develop end-stage heart failure and medication is not enough for them, then we often consider offering them this LVAD therapy or transplant. So in summary, I'd like to summarize what we discussed today. So we discussed how to classify heart failure based on their ejection fraction, the degree of the pumping function, and also based on their symptoms, stage A, B, C, and D. And we also discussed how we offer diagnosis of the newly presented cardiomyopathy patients. We talked about coronary angiogram to rule out ischemic cardiomyopathy, and also other blood tests and imaging modalities to evaluate for non-ischemic cardiomyopathy. And we discussed 4 pillars of the medications that we use for patients with heart failure, which includes ACE inhibitor ARNI, beta blockers, MRA, and SGLT2 inhibitors. And also we discussed what we can offer for patients with end-stage heart failure after optimizing all this medical therapy. Thank you so much for your time and attention, and congratulations again on your opening of the Neurovascular Center. Thank you so much.
Even though I'm not the cardiologist, very much impressed with your presentation, especially the 4 pillar drug therapy and several measures you can use for the terminal stage of the cardiac heart failure. I'd like to ask just one question. Over the last 2.5 years, we have very difficult time due to the COVID-19. So I think there is some possibility use non-contact treatment for the heart failure patient also. So is there any possible way to use as digital hands for the treatment of the heart failure? What is your opinion?
Unfortunately, many of them developed worsening heart failure because they were not being seen. I think digital health, I think a lot of us are trying. I think we have many remote monitoring systems. So for heart failure management, I did not discuss today, but we have implantable pressure measurement device called cardiomams that you can implant in pulmonary arteries of the patients to assess for evidence of pulmonary congestion remotely, for example. And then I think the digital health is often challenging for heart failure patients, unfortunately, because we often rely on physical exam and evidence of the systemic congestion. But as a field, I think we are definitely working on ways to improve that and try to remotely monitor patients with heart failure.